now we are going to talk today on the durable MCS, that is mechanical circulatory support in Indian context actually. So before going to that, how do you feel today in India?
Well, I just love being back here, and what I'm most excited about, and I didn't expect this at all, Charan, is to see over 1,000 people attending this conference. It just warms my heart to see how much excitement there is in India for this field of heart failure and transplantation and durable mechanical support. So I am absolutely thrilled because it now gives me great hope that some of the next most important advances in this field will come right from here, from India.
That's really great to know that. And I think around 1200 registration occurred and 1000 public are there today. So let us come to our talk. So as you know, there are two devices. One is durable and another is, I think, a percutaneous MCS. So please let us know about in detail about what are the availability of those.
Right. So when you're thinking about mechanical circulatory support, it's best to think of them as either temporary or short-term mechanical circulatory devices, sort of those devices that are in the realm of an interventionalist like yourself, and durable mechanical circulatory support devices, which are more in the realm of the cardiac surgeon and the cardiologist. The temporary mechanical circulatory support devices are like ECMO, extracorporeal membrane oxygenation, or the Impella pump,
device,
which are the more common devices, or the tandem heart pump. These are the typical devices. And then, of course, there is the longest existing gateway device, as I call it, the intra-aortic balloon counterpulsation device, which sort of has its own place now. It is has been relegated a little bit to the outside, largely because of the recognition that there has not been sufficient outcome support in terms of clinical trial support with IABPs, largely because they don't provide the degree of support that's
particularly
required.
I think with the shock IABP2 trial,
right.
The sale of IABP has literally gone down. And
it has. It has. So these trials really, it's hard. First of all, it's hard to do a clinical trial where you're testing against medical therapy. Right, and so by virtue of doing those trials, you only have equipoise to enroll patients who are less sick to some extent, and so it's harder to show a difference in some of those patients, which I think is a big challenge in clinical trials. But regardless of what it might be, even outcomes trials with Impella or tandem heart have been inconclusive to a large extent, yet these devices are used much more commonly.
So if you see the utility of those temporary devices, which is the patient-wise population, you feel that these devices will be best for that kind of patient?
So that's a critically great question. So we are seeing two very distinct populations of patients who we think need temporary support. The first is an episodic event. So someone comes in with a large myocardial infarction, cardiogenic shock. They come in, they're critically ill, they need to be helped immediately. And in those patients, really, the IABP can be a gateway device, but it doesn't provide sufficient support. And you need to move to a tandem or an Impella in those patients. Then you have the second group of patients who have chronic heart failure, who are now falling down the cliff. And these patients, as they fall down the cliff, start to get sicker and sicker. And they are what I would call pre-cardiogenic shock. So they start to require IV inotropic support, they start to produce lactate, their renal function starts to get perturbed, and they're just not diuresing as effectively. In some of those patients, who are starting to develop organ failure. In those patients, frankly, you can get by early on with an intra-aortic balloon pump to some extent.
Just
And
as a bridge to the another bridge therapy.
Exactly, exactly. So well said. So as a bridge to a bridge, you know, and that other bridge is a bridge to recovery, hopefully, or a bridge to a more durable VAD. So I think that's how we have framed this in our minds right now in terms of the candidate population. And there's a third candidate population that we haven't talked about, and that's not just the cardiogenic shock population, but the cardiorespiratory decompensation population, in whom a VA ECMO or a extracorporeal oxygenation strategy becomes absolutely critical to employ. And now, of course, that same technology is being pushed to ECLS, where people are in a situation where they have cardiac arrest, and to try and salvage them from the cardiac arrest using ECMO type technology.
So certainly some patient may be also requiring IVP support for as far as circulatory support or a tandem heart, and then along with that for respiratory problem and metabolic problem, probably ECMO would be additional support required in the same patient. Right?
Yeah, so there are a couple of important principles now that you bring up the possibility of either combination devices or sequential devices. So let's talk about that for a minute. One of the interesting things hemodynamically with use of an ECMO pump, for instance, with the VA ECMO, you know, veno-arterial ECMO is common. The problem with using VA ECMO is that it provides relief of the RV, but it actually increases the afterload on the LV.
Yes.
As a result of which, if you need longer than 24 to 48 hours of ECMO support in patients, especially those patients who have terrible left ventricles, if you don't unload the left ventricle, then they go into pulmonary edema, and so their recovery is really impeded dramatically. So very often we use what we call a venting strategy in those patients, where we try and put an impeller pump in.
This is very important thing to, you know, this is phenomenal as far as dynamics of the ventricle as to, one has to very much sure about it, and then you can, in those patients really there is a need of unloading the ventricle in those cases.
Yes.
So now we'll move on to our durable mechanical devices. So as far as durable devices are concerned, I think in US it got US FDA approval in 1998. So since that duration up till now, how do you think is the progress of development as far as throughout the series of devices?
It's a wonderful question, and I'll take you back historically a little bit. So in the 60s, in the 1960s, there was much enthusiasm in the world of the United States. They said, we will go to the moon. And the second thing they said is, we will have a total artificial heart. We are going to create a mechanical heart, and we are going to go to the moon. Well, it turns out that we went to the moon in 1969, but we were unable to develop a mechanical heart, suggesting how difficult it is to fight against nature. And it gives you a very humbling experience of the importance of nature's evolutionary cycle with the heart to some extent, where 4 teams had been given billions of dollars, by the National Institute of Health to develop this wonderful heart. And they said, in 10 years, we will have the most perfect heart.
And it's wonderful to know this.
It started in 1962. Actually, 2 years before the first heart transplant was done. Is when they started to subsidize this. So the first heart transplant was done in 1967. December 3rd, 1967 in Cape Town. In 1962 is when the first meeting was held in the National Institute of Health in the United States to launch the concept. And by 1964-65, they had started to fund these centers. And they said in 10 years we will have it. No, sir. Nothing. Happened. No. So then the concept actually shifted, Charan, from total artificial heart pumping to left ventricular assist devices. So that itself is
to at least a part of it.
Yes, so that's how left ventricular assist devices came into the picture. Is people started scratching their head and they said, look, we are not ready to biologically replace these hearts with a titanium pump. The technology is nowhere ready for that. So why don't we actually just use assist rather than replace?
Yeah.
And then they said, well, let us just assist the left ventricle because it's the most important.
Part, yeah.
And in those days, if you'll recall, historically, hemodynamically, people ignored the right ventricle. Okay,
yes,
I was speaking to one of my colleagues who you would know very well, Dr. Braunwald.
Oh.
I tend to, I have a privilege of sitting with with Dr. Braunwald on a regular basis. And I remember in 2012, I had just moved to Harvard and I met with Gene and I said to him, I said, Dr. Braunwald, in your extraordinarily illustrious 50 to 60 year career, extraordinarily illustrious, right?
Yes.
I said, you have just forgotten one thing. And he said, what? And I said, the right ventricle. You have totally forgotten the right ventricle.
Yes.
And then he told me, he said, in the early 60s, as hemodynamics were developing, we didn't believe in the right ventricle. We thought it was a conduit chamber. And that's why, as you well know, sometimes people will excise the tricuspid valve.
Exactly.
And they say, oh, you don't need the tricuspid valve. You can just excise it in endocarditis. You can just excise it and leave it alone.
Even during your graduation teaching and all, the right ventricle hardly given any importance, isn't it?
And so that's why people said, forget the right ventricle, let's just support the left ventricle. Yes. And now, of course, today we know that by just supporting the left ventricle, we actually uncover right ventricular failure. Anyway, coming back to this important question that you asked. So this history is not new. And it took until 1998, as you pointed out, where the first devices were approved. And this was really following the first concept was, well, these devices are not meant for long-term support. Let's just try and save somebody's life and bridge people to a heart transplant. So the technology evolved as a bridge to transplantation.
First, okay.
And it was then that people started to see a few patients. They saw a few patients who didn't get transplanted and they said, boy, they're doing fine at 2 years.
Why to do transplant?
Why don't we actually consider this as permanent therapy? And that's where this concept of destination therapy came in. And they called it destination therapy, although it's sort of a weird thing to call it destination therapy because almost anything in medicine that we employ is a destination to
Here
something.
I can ask you one question. In destination therapy, do you remember any patient with you who had survived so much duration, means as far as the survival is concerned? Longest survival with the destination?
Yes, so the longest survival in my practice is about 9.5 years.
Almost a decade.
Almost a decade. And the longest recorded survival is somewhere between 12 to 14 years.
Oh, and that was with which device?
They were with the HeartMate devices.
HeartMate 2 and 3.
Very often, of course, one can require replacement of the devices, right? So, so just like with heart transplantation, you can do a second heart transplant. But coming back to that, you asked a critical question, right? So are these devices really truly long term? No. And for a long time, we felt that they were not. Because when we compare it to heart transplantation, the median survival of a heart transplant crosses 10 years. And in fact, the conditional survival, so let's say if someone is transplanted today and they survive to the first year of a transplant, from then on you can ask a question, what's the conditional survival of that patient? It's about 14.5 years.
Oh, that's pretty good.
Right. So first of all, there's no therapy that can actually rival that. But heart transplantation now is obviously the signature boy, but LVADs, durable LVADs, in the most recent trial, the Momentum 3 trial, which we can talk about in a moment, which I had the privilege of leading, at least at the 2-year mark, now rivals the outcome for heart transplantation, 80% 2-year survival.
I think let us move to the next question. You are the author of, I think, Momentum 3 study, which has been published in NEJM 2017. So any particular result with the Momentum 3 you want to tell?
Yeah, when we designed Momentum 3, we were rather brave. We asked many questions. We said, look, we don't know if this new novel device, the HeartMate 3, will be better than the HeartMate 2. We have no idea. Plus, we were putting it in the hands of surgeons for the first time, and you don't know how the surgery is accomplished. It's not the same surgery as the HeartMate 2. So it's different devices, different surgical techniques. So we said, at least let's design a clinical trial that answers something important for us that's quite different. So we, in Momentum 3, we asked the following question. We said, let us stop this whole notion of bridge to transplant and destiny. Let's just take people with advanced heart failure, who have refractory advanced heart failure, who are now failing guideline-mandated medical therapy, most of whom are approaching inotropic support continuously, requiring that for end organ function. And in such patients, if we just randomize them, irrespective of whether they should be transplanted or not, let's see what happens. Yeah. So we were agnostic to the therapeutic intent. That was one of the main things about this trial. The second thing about this trial was that we got very bold. The first LVAD trials had about 100 patients in them. The rematch trial had 60 patients on medical therapy and 62 patients on LVAD therapy. This trial, Momentum 3, had over 1,000 patients. So right about the number of people attending this conference was the number of patients we enrolled in. So it's the largest LVAD trial. Anyway, what this showed is clear. Momentum 3, yeah. Momentum 3 really showed the superiority of the novel HeartMate 3 pump. The HeartMate 3 pump took 20 years to engineer, Charan. 20 years.
Oh my God.
Yeah. And
so you must have started working in 90s.
Yeah, when I was in New Orleans at that time, actually, in a very early stage of my career, when we first heard and started to work on on the HeartMate 3 pump. And this pump is unique because it actually is on a fully magnetically levitated platform. So in other words, it doesn't require any hydrodynamic lift. It can just rotate in air.
So probably the complications are less as far
as
the
and it also correct. It also has very wide flow pathways through it, so the blood is not sheared. It's much smoother. So we see less shearing of blood, which is reflected in the loss of high molecular weight multimers of von Willebrand factor, which you can see with this high shear stress circulation. And we see that that is sheared less with the HeartMate 3. And what we showed in Momentum 3 was almost near elimination of the complication of pump failure and pump thrombosis. Right. But we also showed halving of stroke rates, and we showed a third reduction in bleeding complications. So clearly now we have a device that is much more forgiving. The problem with these devices is that even though we have a much more forgiving device, the device is not forgettable, like a pacemaker or an implantable cardiac defibrillator. And the reason it's not forgettable is that it still requires a drive line that must exit and connect to batteries or to an AC power unit. And that creates a limitation to the quality of life of patients.
Excellent. Let us come to the Indian context.
Yes.
What do you feel as far as this device's utility in India?
Yes.
Considering the socioeconomic status, that is the most important thing, non-availability of the devices, and mostly whatever the devices are being put are there in a transplant centers, not as a non-transplant centers are not there. So what do you feel? So
I think first of all, the more generalizability of these devices from transplant centers to non-transplant centers is only just beginning worldwide. Right? Even in the United States, there are few centers that are coming up that are non-transplant centers implanting these devices. So I'm not worried about that in the Indian context as much. I think the main problem in the Indian context are going to be two issues that you pointed out. The first is cost. Who is going to pay for these devices?
And I think it's 80 to 90 lakhs HeartMate 3's cost in India.
And I think that's a big issue. Price, it's a huge step up for people. And if
when the cardiac transplants, cost is around 20-25 lakhs, and then this therapy cost you 80 to 90 lakhs.
Right.
quite big difference.
Right, it's a huge difference. And
So
then there's a management. So I think what will happen is the following, is my projection, and that's what I'm most excited about at this conference here, Charan, is the following, that India is a land of innovation. You know, jugaad is what Indians do. I mean, how do you think we are on Mars now, you know, orbiting Mars?
But jugaad is, you know, taken in a different way.
Oh, is it a bad way?
Yeah.
So you know that at Harvard Business School, there's actually an entire case teaching on jugaad. It's called jugaad.
Oh, is it?
Yes. It's about how do you actually take a problem and find an innovative solution
and make it
faster, cheaper, and effective, and useful, and user friendly.
Yeah.
So we look at it in the positive context. And so if I've insulted someone, I apologize.
That's okay. That's okay.
But anyway, coming back to this, my excitement in this is that India will hopefully innovate on a cost-effective device. I think that if the manufacturers of these devices do not bring down the price for places like India, India will be forced to do it.
ISRO has already, I think they did the study in the animals,
right,
and are probably coming with the film studies. So let us hope for the best.
Yes, and I think that will be an important future. Now I will caution you that the reason I was telling you all about this history of the evolution is that this is a technology that requires extraordinary precision, and it is not that easy to replicate.
I understand.
So for example, China tried to do this.
Oh.
And do we have a made in China VAD at this time point?
No.
Not one that works.
Yes, definitely.
So
one more question, very interesting. With the development of now ARNI,
yes,
you know, there is a lot of congestive heart failure patients are who were having the class 3 and class 4 symptom now are in class 1 and class 2. So do you think that ARNI will probably change the numbers as far as requirement for the indication of VADs and this thing?
So first of all, any therapy that reduces the transition point from mild to moderate to severe heart failure is a good thing. And I think drugs like ARNIs will definitely reduce the indication. The problem is that the population of heart failure is increasing at a much faster rate than the ability of these medicines to reduce the mortality and to improve the remodeling. One other drug class that I'm extremely excited about, particularly in the Indian context, is the SGLT2 inhibitors. The DAPA-HF trial, which will be presented subsequently, just 3 days ago, reported its top-line results, suggesting that dapagliflozin is actually showing clear evidence of a, as they called it, impressive reduction in heart failure, morbidity, and mortality. Of course, we need to see what the real results are. There's always extraordinary enthusiasm up front. But I'm excited about the future, and I think the less need for VADs and transplant, the better.
Any final words from you for the whole Indian population here as far as heart failure management is concerned?
Well, I would say that heart failure awareness is critical. I think that meetings like this help to endorse the community to move forward. I think prevention is much more important than a pound of cure. And I think the Indian mindset in heart failure needs to move from episodic care of patients, which we tend to have, you know, interventional, with all due respect, to more longitudinal care of cardiovascular illness. And I think that once we reach that focus, the outcome of our Indian patients will be much, much better.
Great. So thank you very much. I thank on behalf of HFTV, Dr. Mandeep Mehra, to come here and enlighten us within a very scientific way for utility of LVADs in the congestive heart failure and advanced heart failure. Thank you very much.
Thank you.